Good morning and good afternoon to our speakers, panelists, and participants across the nation. I'm Carl Pringle, the CEO of Genexus, and we are committed supporters, like all of us are, to the clinical use of pharmacogenetics to reduce adverse drug reactions and inappropriate prescribing. I'm delighted to host this webinar, and frankly, it's one of a kind. With our preeminent position in enabling the clinical use of pharmacogenetics, we are humbled and honored to have such an esteemed lineup of guests to talk about the Right Drug Dose Now Act. So with that, a huge welcome to all of you. I know that we have got hundreds of people from all corners of the nation. And before we get into the congressional offices detailing the implications of the RIGHT Act, we will be joined by Dr. Bernard Esquivel. He's going to talk through a very poignant case study of where pharmacogenetics would have made a significant difference to someone's life. It's important for me to say that we've all heard these individual patient stories, but the sad truth is that adverse drug reactions remain a top 5 cause of death in every major country around the world. And what we do here is going to be felt across the globe. So with that, I am delighted to pass over to Bernard, the Chief Medical Officer of Genexus and a notable global expert on the clinical utilization of pharmacogenetics for better outcomes. Bernard, over to you.
Thank you, Carl, for the intro. It is my pleasure to be part of this outstanding group, and I have to say that I'm thrilled to be part of this conversation. I think this is a groundbreaking time where all the different stakeholders that have been fully engaged in bringing pharmacogenetics and precision prescriber closer to our patients, we are getting into a disruptive time by this proposed act. And I strongly believe that a good way of not only showcasing the benefits of what the bill may bring to our population, but also as a good reminder of why we're doing this, I would like to start my participation by sharing with you a case study. So we have a 61-year-old Asian male who attended the clinic due to painful joints and swollen joints. So once the clinical team performed clinical assessment, medical history, they order laboratory tests, a diagnosis of gout was made. After the diagnosis, a treatment was started, and the treatment was basically using two medications. One of them, the methicillin, 50 milligrams 3 times per day, and the second one, allopurinol, 200 milligrams daily, which it's not uncommon, and it's part of the standard treatment for this kind of condition in this type of patient. And indeed, the patient actually mentioned that he was proving that the pain and the inflammation decreased. But 2 weeks after the treatment, the patient came to the ER presenting this severe lesions in both the dermis and mucosa all over his body. So after the ER team performed their assessment, they admitted the patient with the diagnosis of Stevens-Johnson syndrome. Stevens-Johnson syndrome, it's a severe life-threatening condition many times. And it's a hyperimmune reaction, a mucocutaneous immune reaction, mostly due to mostly due to drugs, medications. So in other words, it's a hyperimmune reaction to external factors, mostly, as I said, medications, with a well-known underlying gene-drug association. So this, and on top of that is well known the interaction or the association between allopurinol specifically and the risk of developing Stevens-Johnson. So one question that we have is, what if this patient, what if pharmacogenetic tests had been performed for this patient? Specifically, talking about that gene-drug interaction, is well known the correlation of a human leukocyte antigen B gene the variant 5801, and the associated risk of developing Stevens-Johnson's when allopurinol is prescribed. So this is a clear presentation on what if we tested this patient prior prescribing this medication. And it is interesting as well to show, and that's the reason why I'm presenting this screenshot at the right side of the slide here. It's interesting that now we're getting more traction from different stakeholders and from different areas of healthcare. Now the recommendations are going beyond the specific or the unique pharmacogenetic niche. What I'm showing here is the 2020 American College of Rheumatology guideline for the management of gout, and it clearly states that testing for HLA-B it's recommended for specific subpopulations, Southeast Asian and African American, against not testing prior prescribing allopurinol. So as I just mentioned, I think we're getting into a point where the clinical evidence, clinical utility, clinical validity, it's in a point where we can bring it close to point of care. So the follow-up question is, could it be avoided? And the answer is probably yes. And it is important to keep in mind that, as I said at the beginning of this presentation, that Stevens-Johnson's, it's a severe condition that may have a mortality rate around 30%. And it has been described that almost 1 in 7 patients with Stevens-Johnson will require mechanical ventilation. Also, according to the data from the 2009 to 2012 nationwide patient sample, the direct cost of Stevens-Johnson in the United States was around $250 million. So it is a healthcare burden. But it's also important to remember that even though we have clearly shared the impact of pharmacogenetic in that case study, it is important to remember that it's just one piece of the puzzle. And it's something that we need to keep in mind in order to continue fostering the right implementation and hence clinical actionability of pharmacogenetics. It is just one piece of the puzzle, and there are several other clinical factors, several other data sets that we need to take into account when prescribing. Some of them, the current conditions of our patient, the previous conditions of the patient, the possible comorbidities that may impact my treatment and my clinical, my prescribing recommendations. It is also important to be aware, how is my patient now? How is the liver function now? How is there any renal impairment that may impact either my dosing or my drug selection? Is there any associated conditions or risks, such as, for example, QT prolongation in patients with diabetes, that may impact the medication that I'm about to choose for this patient? Also, it is quite relevant to always keep in mind the possible drug-drug interaction that this patient may present or that had presented in the past, and we all know that risk increases exponentially when we're talking about polypharmacy, or in other words, the several medications or the number of medication that this patient is currently taking. And on top of that, of course, in order to continue tailoring our treatment, the pharmacogenomic piece will also play an instrumental role. So there are several pieces that we need to take into account when prescribing. And if we continue with our example here, and continue talking about this clinical case and gout. Gout, it's a healthcare burden in the United States as well. The estimated cost of gout are around $7.7 billion, and all the gout specific costs can go up to $20 billion. So it's a major health problem, and it is well known, and it has been described that the cost of care increase exponentially with comorbidities such as renal conditions. So what I'm presenting here, what I'm showing here with the pictures that are in this slide, is what if this same case study had also some sort of a severe renal impairment? We probably we wouldn't be able to use the NSAIDs. We would need to use probably another different anti-inflammatory medication, and even different medications for helping this patient. So all those data sets are crucial when taking a clinical decision, and ideally not only to preventing the onset of adverse drug reactions, but also increasing our efficacy overall on our treatments. And that's instrumental in order to bring pharmacogenetics into point of care. It's critical that rather than trying to continue making the clinicians jump into our workflow, we need to find ways to get into theirs. And this is by bringing all those data sets in a harmonized, evidence-based, user-friendly ecosystem, ideally seamless and fully integrated into the different settings, such as the EHR, for instance, so that we can take advantage of this information. We need to leverage the available resources such as clinical decision support systems that will bring closer to us those relevant factors such as biophysical data, lab test information, current conditions of our patient, liver function, kidney function, previous medications, current medications, and the pharmacogenetic piece embedded into all these clinical factors. I am thrilled also to witness and that this comprehensive, actionable scope is already, and it's also part of the Right Drug Dose Act now. It's clearly mentioned the benefits of bringing clinical support system as a good way of delivering, and it's clearly the benefits, and it's clearly stated within this Right Drug Dose Act now, the benefits of implementing all this information in our workflows, such as, for example, the electronic healthcare system. So exciting times that are coming our ways, and I think we are going to witness some disruptive, groundbreaking momentum in terms of bringing precision prescribing and pharmacogenomics into point of care. So with that, I'll pass it to you, Carl. Thank you.
Thanks, Bernard, for that insightful case study. It paints a really vivid picture for the need for the wider adoption of pharmacogenetics to really enable precision medicine, and not just in a hospital setting, but also actually in primary care. And you know what? It really does require some positive legislation. And that's why we're all here on this webinar, is to get some congressional insight into the RIGHT Act. And we're now going to hear from the two co-sponsors. We're going to start with Representative Tom Emmer. He's a key part of the group leading the charge for the change in precision medicine. And Tom's a real passionate individual and an advocate for this change. Tom, over to you.
Thank you, Carl, and good morning. I'd also like to thank the Personalized Medicine Coalition and Genexus, as well as the individuals involved in helping to put together and host this great event. For those of you who don't know me, my name's Tom Emmer, and I have the privilege of representing Minnesota's 6th Congressional District here in Congress, where I'm also the co-chair of the Personalized Medicine Caucus. As you all know, personalized medicine, or as it is often also referred to, precision medicine, has the potential to save lives and revolutionize treatments by improving early detection, increasing efficiency, and lowering costs. Within the world of personalized medicine, pharmacogenomics, easy for me to say, PGX for short, is an important subfield we've been exploring in the Personalized Medicine Caucus, and it remains a viable path for further innovation. Every person's unique genetic makeup affects drug efficacy, absorption rate, dosage, and ultimately patient safety. PGX can provide this information to a clinician, thereby allowing him or her to develop highly tailored care. Here in Congress, I recently introduced the Right Drug Dose Now Act, or the RIGHT Act, to reduce continuing barriers to the wider implementation of evidence-based PGX testing. Among other measures, this legislation will require an update of the National Action Plan for Adverse Drug Event Prevention. It'll create educational PGX campaigns targeted at public and healthcare providers, and it will improve electronic health record systems to ensure proper reporting of adverse drug events and drug-gene interactions. I look forward to working with my colleagues on both sides of the aisle to move this important bill through the House of Representatives in the coming months. And I look forward to working with all of you. Thank you again for hosting today's event. I'm going to look forward to meeting you, seeing you, and meeting everyone in person very soon. And with that, Carl, thank you again for having me. Have a great rest of the day.
Thanks, Tom, for your insight and all the hard work you and Representative Eric Swalwell have done. is really amazing. Eric is equally as committed as you are to making significant change, significant progress in personalized medicine through the adoption and use of pharmacogenetics and clinical decision support. So with that, I'd like to now pass it over to Eric, your Right Act co-sponsor from across the aisle. Over to you, Eric.
Thank you for joining this important briefing about pharmacogenomics as a catalyst for precision medicine. The ability to predict ahead of time which drugs will be effective for each patient and determine which medications may cause patients serious issues will save lives, improve healthcare outcomes, and decrease healthcare costs. Access to pharmacogenomic testing is critical to evaluate an individual's genetic makeup and identify which medication and which dose is right for each patient. Many genes play a role in how people respond to medications, including how effective they will be, how quickly medication will be metabolized, and whether a person is likely to experience side effects from a particular drug. In fact, adverse drug events are the most frequently cited significant cause of injury and death among hospitalized patients. That's why Republican Tom Emmer and I introduced the Right Drug Dose Now Act, or the Right Act. This bipartisan legislation will improve education and implementation of pharmacogenomic testing to reduce adverse drug events. The bill would also improve electronic health record systems to ensure that healthcare providers are immediately alerted to interactions between medications and genes when making prescribing decisions. As many of you know, information about drug-gene interactions is not well integrated in patient care and tools like electronic health records and can help bridge the gap if we do this. Thank you again for joining today's briefing and for your interest in the Right Drug Dose Now Act.
Thanks, Eric, for that great insight and all that you're doing and why you're doing it for the Right Act. It's been really wonderful working with you and your team. And again, deep thanks to you and Representative Emmer for your ongoing support of the Right Act, and particularly now as it goes through the legislative process. And fingers crossed that it'll be smooth sailing and we'll go through quickly. Now I'm delighted to introduce Megan Anderson Brooks. Megan is a principal with Innovation Policy Solutions, and they've been highly engaged in developing the content for the Right Act. Megan is going to provide us with some insight, some detail, and kind of a behind the scenes look at the Act and the process. So Megan, over to you.
Thank you for the invitation to be here today. I'm honored to have the opportunity to share more information about the Right Drug Dose Now Act, or the Right Act for short, a critical piece of legislation to overcome some of the various barriers to PGX adoption. As was mentioned, my name is Megan Anderson Brooks, and I'm a principal at a DC consulting firm called iPolicy Solutions. And our clients have been actively involved in PGX advocacy in DC over the past several years and/or endorsed the Right Act. This bill was introduced not too long ago on February 28th by Congressman Eric Swalwell from California and Tom Emmer from Minnesota, whom you just heard from. They are both chairs of the Personalized Medicine Caucus, and I'm greatly appreciative of their efforts to advance policy that improves access to precision medicine. The Right Act was introduced into the US House of Representatives, and definitely expect organizations to be actively advocating for not only additional members in the House of Representatives to join as co-sponsors, but also for senators to champion the introduction of the bill in the Senate as well. Turning to what the bill would accomplish, I thought it would be helpful to review the bill by framing its various elements by the barriers that it would ultimately address. So starting with the first barrier, being a lack of knowledge about PGX in general. It's probably not surprising to you that many people are not aware of what the term pharmacogenomic even means, and even more do not understand the benefits that the adoption of PGX information would bring to patient care. This lack of knowledge exists in both the general public and among healthcare providers as well. Even in our own advocacy efforts around the bill, many organizations don't understand how far the field has come over the past decade and why PGX is relevant to the disease or health condition that is interest to them. That being said, the US federal government is highly aware of the issue of adverse drug events. And a number of years ago now, Senator Michael Bennet from Colorado and former Senator Olympia Snowe from Maine called upon the Department of Health and Human Services in the United States to establish a task force to reduce adverse drug events. HHS responded by doing just that. The Office of Disease Prevention and Health Promotion brought together various federal agencies and experts to create a national action plan for adverse drug event prevention, which was finalized in 2014. It had two objectives. The first, to identify common, preventable, and measurable adverse drug events that may result in significant patient harm. And two, to align efforts of federal health agencies to reduce patient harms from these specific ADEs nationally. It focused on 3 drug classes: anticoagulants, diabetes agents, and opioids. And this task force that was established, called the Federal Interagency Steering Committee for Adverse Drug Events, they approved 6 measures to assess the progress of the ADE action plan with targets set for 2020, and the year is now 2022. In order to better promote awareness of how PGX can contribute to the reduction of adverse drug events, the RIGHT Act would do several things. Just to start, it would require HHS to report to Congress on the implementation of the 2014 ADE action plan. Secondly, it would require HHS reconvene the Federal Interagency Steering Committee for Adverse Drug Events to update the ADE action plan, and in particular, ask the committee to consider the role of drug-drug gene interactions. This in particular is an important opportunity for incorporating all of the new PGX information that has been gleaned over the past 8 years into this national strategy. Lastly, the committee would be tasked with evaluating FDA's adverse event reporting system and how it could better enable pharmacogenomics research. And this will be relevant later when I talk about other aspects of the bill, and I'll come back to it. Secondly, the bill would lead to the development and implementation of 2 educational campaigns for the general public and for healthcare providers to improve knowledge about adverse drug events and clinically appropriate use of PGX testing. I look to the success of the Breast Cancer Education and Awareness Requires Learning Young Act, which created educational tools to increase young women's breast health awareness and support of young women diagnosed with breast cancer. And that legislation included both public and healthcare provider education programs as well. You might be familiar with the Centers for Disease Control and Prevention's Bring Your Brave campaign. And so thinking about the success of that program as part of the RIGHT Act, you have both the public campaign and the provider education campaign as well. As part of the public campaign, this would lead to the development of evidence-based messages and materials about adverse drug events and associated risk factors, in addition to providing basic information about PGX testing and comprehensive medication management. There's also a subsection of the bill to ensure that educational efforts reach rural and underserved communities in particular, and I know this was really important to the bill sponsors. HHS would also be able to award grants or contracts to help establish this national multimedia campaign as well. As part of the provider education program, one part that I greatly appreciate is that the bill focuses on a range of healthcare providers that can play a role in the use of PGX information. The list in the bill includes a lot of different healthcare providers, but just to name a few: pharmacists, nurse practitioners, laboratory professionals, medical geneticists, genetic counselors, etc. And not only would the program focus on providing information about the appropriate use of pharmacogenomic testing and information in patient care, but it would provide information to healthcare professionals about other providers that would be relevant to include when making prescription drug decisions. As you can see on the slide, HHS would be able to award grants to nonprofit organizations to assist with carrying out this program as well. And so in order to fund all of these campaigns, the bill authorizes $50 million each year through fiscal year 2027. Turning to the second barrier, the failure of most electronic health systems to incorporate genetic information and the lack of the use of drug alert systems for PGX-related information is a significant barrier to efforts to adopt a personalized medical approach to medication management. It is incredibly important that patient-specific information is flagged for providers at the time of care. So in order to resolve this issue, one section of the bill makes use of an existing health IT certification program, which is run by the Office of the National Coordinator for Health Information Technology. And under current regulations, in order for health IT to be certified, interventions must automatically indicate to a provider drug and drug allergy contraindications that would be relevant to the specific patient. The RIGHT Act, the RIGHT Act would require that ONC update the criteria to include drug gene and drug gene information as well. The result would be that EHRs would have to meet these criteria in order to qualify for the use, and CMS is promoting interoperability program, which is meant to encourage the use of certified electronic health record technology. So ultimately, this would be a very powerful incentive to the adoption of EHR PGX tools. Secondly, the bill requires that regulations be established to ensure alerting systems are continuously updated as new PGX information is gleaned. Obviously, that makes a ton of sense. So the final barrier is meant to address barriers relevant to preventing further PGX research. And I'll start by talking about adverse drug event reporting. The ultimate goal of this section of the bill is to create even more rich source of information to allow researchers to better understand any relationship between genes and certain medications. From the perspective of how many populations it is relevant to, the FDA adverse event reporting system is significant, and the bill would require HHS to work to ensure that information about adverse drug events from EHRs can flow to FDA's system, and in turn, that FAERS can accept such information. Importantly, the bill would require that FAERS be updated to include a selection tool to easily allow for when an AD is associated with a drug-gene interaction to be flagged by the person reporting it. Lastly, it will require that FDA would work with other agencies and stakeholders to create an even more patient-friendly option for reporting information, including by exploring the development of a mobile app. While there are lessons learned that should be considered, millions of patients became familiar with reporting adverse events associated with vaccination through vSafe during the COVID-19 pandemic. And I think it's an important consideration, especially because of the creation of the public education campaign via the earlier sections of the RIGHT Act. Finally, there's much more to learn, and the RIGHT Act would support the advancement of our pharmacogenomic research by directly providing funding to the National Institutes of Health. It would authorize $7 million to be appropriated to the NIH for fiscal years 2022 through fiscal year 2025. And the bill specifies that the funds would be used to conduct, support, and maintain PGX implementation research. For instance, you might be familiar with the Clinical Pharmacogenetics Implementation Consortium, or CPIC, which develops clinical PGX guidelines, and the consortium is supported by NIH funding. That brings me to the end of the bill, so I will end by inviting you to learn more and joining our advocacy efforts by visiting the fourthcause.org website on the RIGHT Act, which is operated by the American Society of Pharmacovigilance, and I greatly appreciate their partnership on all of this. And I'll stop there and turn it back to my colleagues on the webinar. Thank you.
Thanks, Megan. Thanks for that comprehensive overview. The work you and the congressional officers have been doing is so important, and it's so needed to affect the change that, that frankly is so long overdue. So now let's move to the panel session. We're going to be joined back by Bernard. Megan's going to join us, and we're also going to be joined by Sarah Shapiro. Sarah's from Representative Swalwell's office. She's been involved in the creation of this bill, this act, from the very outset. So we're super lucky to have both Sarah and Megan here who know so much about it and to answer some of the questions that are coming through. Why don't we start, Sarah, by you just giving a brief introduction of yourself, please, and your involvement in the act so far.
Hi, everyone. Can you hear me okay? Great.
Perfect.
Thanks so much for having me and for providing such a robust discussion on the bill. and pharmacogenomics in general. I'm really excited to bring more light to this issue. So my boss, Congressman Swalwell, got involved in this and personalized medicine in general a long time ago, after dealing with his own one of his own kids and so many constituents coming to him about having children going through the diagnostic odyssey, average of 7 years to diagnose a rare disease. And so he started with appropriations requests in Congress of trying to get more research for rare diseases. And then that stemmed into creating the Personalized Medicine Caucus in Congress with co-chair Congressman Emmer, who's been a great partner on this issue. And then we also introduced legislation on genetic testing, and we're really excited that got included in Cures 2.0. And so he really wanted to dig into the weeds on an issue that hasn't gotten much attention. And in fact, former Senator and former President Obama, when he was I believe his second year in Congress, introduced a bill on pharmacogenomics. And fortunately, it didn't get to move that far. He wasn't in the Senate all that long. And so, he sort of put a marker bill out there, but other than that, there really hasn't been much focus on this issue in Congress. We wanted to bring more research dollars to preventing adverse drug events, and then also bring more awareness both in the general public and in the medical community.
Great, thanks, Sarah. And sort of aligned to that, one of the first questions that came through, and maybe since you've started speaking, we'll continue with you. The first question is, when did you start working on the bill? When did it kind of give us a bit of that history? Who were the key stakeholders that you were working with, or industry groups? We heard Megan reference CPIC. Were there any others that you brought in, and are there any others maybe perhaps in the future that you want to bring in?
Yeah, absolutely. I think it was about 7-8 months that we were working on this, and Megan's been such a wonderful partner as well. There are a number of companies, including Invitae, that are really wonderful advocates for increased pharmacogenomics research. And so we started there, and then worked very closely with the Personalized Medicine Caucus. So a really nice benefit of that group is how diverse it is. It includes diagnostic companies, health insurance companies, IT and informatics companies, clinical lab testing, research companies, and then also patient advocacy groups. And so being able to get all of those diverse constituencies in one room, all advocating for one policy is really beneficial and helps us get a lot of this work done. So very grateful for the Personalized Medicine Coalition as well. And then, yes, definitely would reiterate what Megan said about CPIC. They're the ones doing the work currently. And we were shocked at how under-resourced and underfunded they've been, given the vast amount of tests that they're conducting every day. So I would say those are some of the really helpful stakeholders that sort of got us from bill idea to introduction.
Yeah, excellent, good. And by the way, for the audience members out there, we've had a flood of questions coming in during the course of the webinar so far. If you'd like to submit them, use the Q&A button at the bottom of your screen. Okay, so second question, and perhaps Megan, you can comment on this, and Sarah can backfill any bits of other information. And that is really, as you've been working with these stakeholder groups, are there any specific implications that the healthcare industry needs to be aware of in applying pharmacogenetics and utilizing pharmacogenetic testing? For example, will they need to change the way that they do business when this becomes law?
That's a good question. I think when we started thinking about the bill, we were really thinking about how essential pharmacogenomics is and how many individuals didn't know about it. So the ultimate goal was really just to elevate this issue and bring more awareness both among healthcare professionals and the general public. I think that was really one central goal. And I think, just thinking about it from that perspective, the ultimate outcome is just making sure that more patients are getting better care. And so whatever we can do to accomplish that, that was what was really tied into like, okay, well, what are the barriers to people getting that information? And, when I think about a more ideal world, considering that an estimated 99% of people have a genetic variant that plays a role in how they respond to a medication, ideally you want to be able to offer someone testing if they think it's appropriate for them, so that this information can be used and it can be a part of their health record before they become ill. And you can more quickly and more efficiently deliver care for that person when it's relevant for them. And so something that stands out to me when you ask that question is we held a congressional briefing a couple of weeks ago. And, the intent of that is just to educate more congressional offices about this piece of legislation and the issue more generally. And we were really honored to have Dr. Heidi Rehm from the Broad Institute participate in that event. And she noted one of her experiences with providers and there being a lot of hesitation with ordering comprehensive testing because they just didn't want the responsibility, I'm paraphrasing here, of just handling that much more information that's not directly relevant for the care at present. And so, how do we better create a system that can handle more comprehensive PGX information so that patients have it when it's relevant for them? Because you may not know that you're going to need that medication in 5 years, but it's quite possible. And so I think when we think about like how can businesses better respond to what the future of the RIGHT Act might bring, it's just thinking about responding to an environment where more providers are aware of the need for this information and creating those tools to support a patient having that PGX follow them over time. And I know that so many of you are already creating those tools. So it's really just about being ready for that, what we hope is that new future.
Yeah, great. Thanks, Megan. And I remember vividly those comments that Dr. Heidi Rehm made as well. And that kind of dovetails into one of the other questions that we had very closely. And Bernard, I'll direct this one to you. And that really is exactly what you were building to there, Megan, which is how can we bring pharmacogenetics sort of to the front line, to the point of care? One of the questions exactly was, what are the major barriers to the implementation and the utilization of pharmacogenetics in that 10 to 12 minute consultation? Bernard, would you like to comment on that one?
Sure, thank you. I think it's a great comment. And at the end of the day, I think that's the next step, that is the implementation, right? How we're going to be bringing this closer to point of care. So, and there are several factors that we need to take into account and ideally address. Number one would be training and education. I think that's instrumental, and that's one of the main milestones that we need to achieve. We need to bring clinical utility, clinical validity, clinical actionability. It's out there. There's enough evidence has been published, and as Megan mentioned, CIPIC has been doing a great job standardizing this information, bringing this information closer to clinicians, and it's something that we can leverage, and it's something that different clinicians are and should continue getting more access so that we can feel more comfortable utilizing this information. The second one would be, it's important to remember that we need to bring this into our ecosystem, into the clinical ecosystem. So that needs to be embedded into the way we normally practice, and that's into the EHR. I think that's critical and instrumental. We need to how we're going to be delivering this information. It needs to be delivered in a way that can streamline my process, that can help my clinical day-to-day practice, and can ideally make my practice more efficient, not only for prescribing but also for de-prescribing. And that's bringing closer by, for instance, leveraging such as clinical support systems into the EHR. I think that's instrumental, and therefore it's making this information dynamic instead of static. I mean, the reports, the usual pharmacogenetic reports that we normally see out there, they are static, and that's information that we don't know if it's been how recent and up to date that information is. So we need to have dynamic information that can be connected with the EHR again, and so that we can have real time or as real as we can have information from our patients, so that we can bring PGX, as I said at the beginning, as another piece of the puzzle, so that we can optimize our prescribing or the prescribing practices. And I think, last but not least is what we are actually doing here. It's something that goes beyond a specific interests. It's something that needs to bring together all those stakeholders from the industry setting, from the academic setting, from the clinical setting, from the governmental setting, and keep this conversation going so that we can bring this closer, and that's what matters, closer to our patients.
Yeah, great, Bernard, thanks. And that's an interesting point you make there about deprescribing, because of course, naturally everyone thinks about the use of pharmacogenetics for prescribing the most accurate and personalized medication for a person. But of course, it can be used to make deprescribing decisions as well, which, brings it into the pharmacist's area of work and enabling them to operate at the top of their license. You mentioned they're one piece of the puzzle, and there, as you kind of allude to, there's a number of pieces of the puzzle there, and one of those is ethnicity and race. And one of the questions that we had coming in is, what are some of the limitations and opportunities of assessing and applying race ancestry criteria to identify the right people for pharmacogenetic testing? Bernard, do you have any thoughts on sort of a pan-ethnic approach for screening for high risk, high impact variants like the HLA gout as an example?
Yeah, I think that's a great question. I think that's something that should be endorsed in terms of continuing or keep fostering research, because the reality it is different. The ethnicity or the background of the patient may represent a different genotype, or even more importantly, a different phenotype, and we have seen that on one of the most common pharmacogenomics implicated genes, that is CYP2D6. So, there's a lot of it we need to continue doing here. We need to continue increasing our testing so that we can have specific subcohorts or subpopulation samples, so that we can, in other words, compare apples to apples. And the second piece is from the lab perspective. Most of the times we're using self-reported ethnicity as part of taking that information. And ideally, we will need to take this into the next level. We will need to define the ethnical background of our patient, so that we can therefore compare apple to apples. That's something that it's well known within the pharmacogenomic space, and it's something that many groups are working, and that's then again one of the biggest benefits, and one of the many reasons why CIPIC has been so successful, because we are, as part of CIPIC members, we are all over the world, and we are sharing information, and we are sharing data, and we are reviewing data from different parts, allowing us to cover those subpopulations and be more accurate when implementing pharmacogenetics.
Yeah, great. Okay, the next question sort of goes back to the policy and the Right Dose Act now Act. And Sarah and Megan, is it will the Act help patients get access to genomic testing?
I can. Go ahead, Megan. I'll jump in after.
Okay. Well, I mean, that's ultimately the hope. Certainly, one big part of it was ensuring that all of the recommendations and messaging that was being put out to the public and healthcare providers was evidence-based, either, being informed by FDA label or CPEC guideline or some other appropriate guideline. And so ultimately, that's the hope, but really leaving that to the conversation between provider and the patient to decide whether that's appropriate for them and their care. But I think if people don't even know that it might be relevant for them, that's really the biggest barrier that they were trying to overcome. Sarah, please feel free to jump in.
Yeah, exactly. We think the most important first step is to A, increase awareness, and B, get this information integrated into electronic health records. And a lot of that will already be covered with primary care and other types of care. For specific diagnostic testing, that's certainly a separate piece that I think we'd like to address kind of as a second step here. If we're able to get this included in a package or passed, then we sort of set the stage for PGX as a part of primary care. And I think we'd be in a better place to do that.
And I'll just add, I see some comments about the role of pharmacists, and I absolutely agree with those comments in the chat, and which is why when I know we were brainstorming about like what can be done, wanting to make sure that the list of healthcare providers was expansive, included pharmacists, because I agree that they serve a very important role for already being so involved with raising certain indications or contraindications that might be relevant for a patient, but especially during the pandemic, seeing the way that they've been involved in offering testing and thinking about how in the future can pharmacists be involved in other parts of healthcare and perhaps pharmacogenomics. So I just wanted to add that piece and offer my praise for people who are raising that issue for people in the chat.
Yeah, that's great. And you know, they're a super important stakeholder group, and actually, you know, they in many respects, the pharmacist community are leading the charge in the utilization of pharmacogenetics. Another group that is very active and increasingly more important are the role of the genetic counselors. And one of the questions that has come in from genetic counselors is, was there any sort of specific role of the counselors in this bill? Is there any sort of perspective or view of whether they'll be able to order pharmacogenetic testing? Are you aware of any other legislation that kind of dovetails into that? Sarah or Megan?
I would start with and let Megan feel free to jump in as well, but that the education campaign for healthcare providers could include genetic counselors, and I think that's definitely an important part to, you know, make sure that we're targeting funds to make sure that they're getting the resources and education they need, as these guidelines are constantly evolving and the discoveries of drug gene and drug gene interactions are constantly evolving.
Yeah, and I'll add to that I think it was really important that you know, so many stakeholders were involved in the way that the language ended up taking shape, was just ensuring that healthcare providers were aware of the medical expertise like genetic counselors that are out there available for use. So just making sure that a broader range of healthcare providers are thinking about, oh yes, I could reach out to a genetic counselor to be involved in as part of this conversation. And just thinking about legislation that might be relevant, not directly relevant to this legislation, but obviously so many of the stakeholders that are involved in this conversation are also supportive of the Access to Genetic Counselor Services Act. And you know, would love to see that bill advance as swiftly as possible too. So just wanted to note that as well.
And if I add, Carl, from the clinical perspective, number one, I entirely agree in terms of the pharmacists are the ones that should be the ones championing this initiative from the implementational standpoint. And secondly, it's something as, for example, when we order, clinically speaking, when we order an MRI or a CT scan, you leverage and you rely on the experts in order to bring the best possible solution to your patient. So you have the radiologists that will help you to better understand what are you seeing there. It is the same thing with pharmacogenetics and precision prescribing. You have the genetic counselors that will help you not only to get that information, but also bring that information to the patient in a way that the patient can understand and own that information, because that's the key factor in personalized medicine. The patient should participate and own that information, and also leverage the pharmacists or the experts here so that you can help you tailor treatments and customize your treatment for those patients.
Thanks, Bernard. Okay, the next question is about sort of about insurance and having pharmacogenetics as a covered benefit. And you know, this kind of falls under the much broader umbrella of reimbursement, which there's all sorts of necessary talk and discussion going on. Megan or Sarah, in your involvement with the stakeholder groups, has there been any sort of discussion, any kind of guidance that you're hearing around pharmacogenetics being covered for certain conditions, certain medications?
It's interesting that you bring up reimbursement, just because it has been a part of the conversation about what are some of the other barriers that are out there. And so, I'll just say that I think that this bill is such a significant step forward. And, the goal was to try and resolve as many barriers as possible. And I think that there's a lot of positive things happening in the reimbursement space. So my hope is that just we keep building momentum for more positive coverage and reimbursement decisions out there. And hope is, again, that we'll generate that momentum and that we do have champions among our policymakers for caring about these issues. So yeah.
Great, thank you, Sarah. I think this next question is a good one for you, and it's about the $7 million for research that's in the Act. Is there a plan to increase that? Were there some ideas in terms of how that $7 million may be utilized? Was it based on the number of kind of specific projects? Any kind of detail you can provide there?
Yeah, absolutely. And that's great timing as we are in the middle of appropriation season. So really the issue that we ran into is that the Genomic Community Resources Program within NHGRI doesn't have its own appropriations line item. So really getting in the nitty gritty of how funding is allocated. But that means that, this pool of funding for NHGRI is going to NIH, but within that, they're not required to spend a certain amount on the Genomic Community Resources Program, which is really the only federal resource being used to determine drug-gene and drug-drug-gene interactions. And so we wanted to make sure that there's specific funding being allocated each year to continue this study and research. And so we are leading an appropriations effort this year to do just that.
Great. Okay, so we just have time for a few more questions. The next one is about the RIGHT Act supporting the consistency of pharmacogenetic implementation and the interpretation of the results, so that there's sort of consistency across. Has Megan or Sarah, has there been any thought of that consistency of how pharmacogenetics is used, the interpretation of it, standardization in the Act, or is this part of that research and education appropriations process that you're going through now?
Exactly. We want to make sure that the department has the resources to do just that. I mean, they're working with a very small team currently, and they have a lot of incoming data that they just don't have time to analyze. So exactly, that's the goal.
Okay, and the other question that has just come through from the pharmacy community is, will the RIGHT Drug Act affect the pharmacist's role in patient care, reimbursement, or provider status, enabling them, for example, to order pharmacogenetic tests or get reimbursement as a result of using pharmacogenetics?
Yeah, I'll let Megan jump in with any more details there, but it does not address reimbursement directly. That would kind of change the process for being able to get a bill to move. But I'll let Megan jump in as well.
Yeah, and I'll say, I think about like my work within Vitae in particular, they're very supportive of changing pharmacist status to ensure that they're reimbursed appropriately, and are excited about that policy of movement. And I agree that like thinking about the role of the pharmacist is important. And so while the bill specifically doesn't dictate to HHS how those education programs should be structured, and clearly HHS would be allowed to solicit ideas and input for those education campaigns. My own personal preference would be that there is a strong emphasis on involving pharmacists in these care decisions, and since they are interacting with patients so often about their medications. So I'll just say that would be the hope, and very supportive of all of those efforts to support pharmacist reimbursement.
Yeah, great. And I think, Megan, that kind of dovetails into the final question that's come through that we have time for, which is, would you, and maybe this is for all three of you actually, would you consider the RIGHT Act as sort of the foundation for other important healthcare policies around pharmacogenetics that would include coverage, that would include reimbursement, that would include access, that would include these other provider clinician groups that Genexus as well is very involved in educating? How do you see that?
Well, I can start and just say, I don't want to take too much credit here, but we're just really excited to have a bill to start the conversation here. I mean, going back, again, to former President Obama's bill when he was a senator is really the only time there's been a bill in Congress in this issue. And so it's really to start the conversation, increase awareness, increase resources for the Genomic Community Resources Program, and get more members to care about this issue.
Yeah, and the work is really never done. And, so many offices, as I mentioned, just the general public just don't even know what this term means. So I invite you all to help in those education efforts. I know that we're going to be very busy trying to generate as much enthusiasm around this bill. I mean, ultimately, my hope is that the leadership feels like this bill can move very swiftly. I mean, it just makes sense. This bill makes sense. So, and I mentioned like the work's never done, and just echoing what Sarah said about the appropriations process, there are two pieces of the bill that authorize funding. And so thinking about just continuing to support the outcome if the RIGHT Act becomes law, thinking about, okay, how do we support these programs for the long haul? And from there, I think we've really set ourselves up nicely to have interagency committees continuing to talk about this for many, many years to come, supporting further development of guidelines and really increasing just knowledge about the space in general. So I completely agree with the word, the RIGHT Act being a foundation for many years to come.
Yeah,
and
great.
it's also unified. It's also a first step of showing a unified front, and I think that's also what matters. Now we're seeing different stakeholders working together, and that's the ground level we need in order to keep building and getting into a point where we can bring this as standard of care. So I agree 100%.
Yeah, and Sarah, in terms of sort of the next steps with this act, what's the process? When does it get voted on? People hear about, oh, it gets marched up the hill or down the hill. I'm never sure which way it is. Could you provide a little bit of insight into that process?
Yeah, of course. I wish it was as seamless as you introduced it and that's it, but there is still a lot more to do. So we would love to get a markup for the bill, which means that it's considered and voted on in the committee of jurisdiction. So that's Energy and Commerce. In the meantime, we're just trying to get co-sponsors. It's always harder on bills that staff and members aren't as familiar with. So if you all represent advocacy groups or companies, think about who your congressman or congresswoman is. Please reach out to them, encourage them to become a co-sponsor of the bill. Building support with other members is the next step, really, to get it to a committee markup to be passed out of the Energy and Commerce Committee.
Excellent. Well, perfect. Thank you very much. Like as we wind up here, I just want to say that the RIGHT Act really, it's a pivotal moment in the adoption of pharmacogenetics and associated clinical decision support software to make healthcare better, to get improved outcomes. It's long overdue. So hats off to Megan and Sarah for your drive and commitment, and the offices of Representative Emmer and Swalwell for the commitment and participating in this webinar to educate us all. So before we sign off completely, I'd like to announce our next webinar, sort of continuing this theme and looking at something that was pretty prevalent in the Q&A today. And that's about how do we actually get pharmacogenetics to the front line, part of the clinical workflow, whether you're a physician, whether you're a pharmacist, a genetic counselor, or otherwise involved in pharmacogenetics. So we'll really dig into the clinical decision support aspect of it with embedded pharmacogenetics, and we'll have another stellar lineup. So Megan and Sarah and Bernard, thank you so much for participating, and everyone else for attending this this webinar today. Goodbye.